Assalamu alaikum. It's really my pleasure to introduce Dr. Hawazin Darif. She is Associate Dean, Academic Affairs College of Medicine, Female Medical Student Branch in Jeddah. She is also consultant endocrinologist, and she is the head of the Department of Endocrinology at the King Abdulaziz Medical City in Jeddah. Really, she will talk today about a very important topic. She will talk about new advance in hybrid closed-loop insulin pump. Dr. Hawazin, you can start, please.
العافية. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I would like to take this opportunity to thank the organizing committee, Dr. Saud al-Sifri, Mr. Majid, Dr. Iman, Allah يعطيكم العافية. So the topic that I'll be talking about today will be new advances in the hybrid closed-loop insulin pump. So I will start by describing the history of the continuous subcutaneous insulin infusion and the continuous glucose monitor. I will be describing some practicalities of the initial hybrid closed-loop system, insulin delivery system that was released a couple of years by Medtronic. And then I will just briefly mention about the advanced hybrid closed-loop insulin delivery system that will be available soon, inshallah. Okay, so let's go back and talk about 100 years ago. So all we know and we remember this date very well, the date of 1921, the date when the insulin was discovered by Frederick Banting and Charles Best. Since that time, over 100 years, there have been various developments in the field of insulin. And starting back in the 1960s, the insulin pump development has started. So the devices that were designed, they were designed to mimic pancreatic endocrine function, and they have been developed since the 1970s. Initially, as we can see from the photo, that they were very complex. They were intravenous insulin infusions. However, later on, with the introduction of the bolus on top of this insulin, Tamberlin was able to be the first to use the insulin pump with, in addition to the continuous subcutaneous insulin infusion, he was able to introduce the bolus insulin. In 1983, the Minimed commercialized their first insulin pump, the 502. And soon after that, the pump and the vision for the development of the artificial pancreas has started. Parallel to that was the development of the continuous glucose monitors. So the development of the CGM was the next major step in creating the artificial pancreas, or on the road to the development of the artificial pancreas. So in 1999, the FDA approved the first physician-use CGM. The CGM technology progressed very rapidly. By 2005, there were almost 5 devices available. And then by 2006, the Juvenile Diabetes Research Foundation launched the Artificial Pancreas Project and has been funding the development of this area since that time. So if we go to the foundation pump that was first invented, or that was first released by the year 2006, the Minimed paradigm, the first pump that integrated both the insulin pump as well as the continuous glucose monitor system. As you're aware, it shows the real-time continuous glucose monitoring data on the pump, and it delivers the alerts and alarms based on the sensor values. A few years later, up to the year of 2013, the insulin pump, together with the CGM, was able to take action. So now, with the presence of the inlight sensor, the pump has the automatic stop or suspend of insulin delivery when the glucose reaches a low threshold, and that was by the Minimed VO and the Minimed 530. And then a few years later, by 2015, 2016, it was even further advanced. So now it can stop insulin even before the sensor reaches low. So it predicts that there is a low threshold that is going to happen, and it actually suspends before this low threshold. And then after that, once the blood glucose recovers, the insulin starts pumping back again. Later in 2016, the hybrid closed loop was developed, the Minimed 670G. And that, in addition to the suspend before low, it had the automatic basal insulin delivery. So the physician does not need to sit with the patient and do the calculations and do the hourly basal rate adjustment. So it is automatic. So the patients would need to actually calibrate, and also would need to enter the meal carbs. So we will stop at this stage at the to discuss further the hybrid closed loop insulin pump. So in order to have a successful closed loop insulin pump, it is based on an infusion algorithm. So you have to have a very good designed infusion algorithm. And on top of that, you need to have a quality of CGM. So the monitor needs to be of good quality. And this is measured by the mean absolute relative difference, the MARD. So the MARD is, or the mean absolute relative difference, is the difference between the laboratory, sometimes they use fingerstick glucose, and the sensor glucose. And since it's a difference, so the lower the MARD, the more accurate is the sensor reading. And some studies on this was conducted in 2017, and they found out that the MARD is around 10%. It could be a little bit above 10% if you're calibrating twice a day. The more you calibrate, like 3 to 4 times a day, then you would have a MARD below 10. So anything that is in the range of 10 and below is considered a good CGM. So something that we have to discuss here is the 670 and the function of the 670G. So the 670 insulin pump has threefold function. So it functions as a continuous glucose monitor. It also delivers insulin. And in addition, it has the capability of controlling the hormone delivery. The third part is what we consider as the brain of the pump, because it's controlling hypo and hyperglycemia. So it's providing a sophisticated automation when it is in auto mode. So the Medtronic 670G can automatically adjust the basal insulin delivery every 5 minutes based on the sensor glucose to maintain a blood glucose levels at a specific target. And in addition, the suspend before low function that was in the previous pump, the 640, would also prevent hypoglycemia. It predicts hypoglycemia, and it would prevent hypoglycemia from occurring. So the 670 insulin pump has 2 different modes, auto mode and the manual mode. And we'll talk about this in details. So what do we mean by manual mode? The manual mode is basically what is available in the current insulin pumps. So we all know that when you want to initiate insulin pump therapy to your patient, you have to review the total daily dose on if the patient was on multiple daily injections. And from that, you would subtract about 10 to 20% based on his diabetes control. And then you would consider that 50% of the total daily dose delivered via pump is the basal rate. You would divide it by 24 hours. So you would have the hourly basal rate. And then there is some formulas that we know how to calculate the carb ratio. You divide the 500 by the total daily dose, and the sensitivity factor, you divide 1,800 by the total daily dose. And then you need to also enter the active insulin time, or the insulin on board, which is about 3 to 4 hours on average for most of patients. And then you set the target depending on the patient, the age, the duration of the diabetes, whether or not the patient has complications. So all these factors you need to take into consideration when setting the manual mode. And after that, once you calculate the hourly basal rate, as we can see from the graphs here, that the basal rate throughout the 24 hours is variable. So it is not a flat curve that we see in case, for example, we're using a long-acting insulin, like, for example, insulin glargine. However, we can see here that there is variability. So we have this dawn phenomena in the early morning, and then probably later in the afternoon. The requirement of insulin decreases later at night. It increases early hours of sleep. Again, it decreases. So it's variable. So this is the whole idea of setting an hourly basal when setting the insulin pump. And then we go over a 24 hours coverage to determine that rate, and we enter that value in the pump depending on the history that we take from the patient, usually the time of waking and sleeping, the timing of meals, if there are any activities involved, at time where you're less active, etc. So the manual mode is basically when you use the pump as just a regular pump that is augmented with a sensor, and on top of that you would have the automated smart guard features, which is either actually both the suspend before low with resume basal or suspend on low. So when you're using the manual mode in the 670G, you have this hourly basal rate that is delivered, and all the information that you need to install in the pump as a regular pump. In addition, you have the suspend before low and the suspend on low. So both of these features will work to minimize the lows by stopping and restarting the pump in response to the patient's sensor glucose. So for a patient, when you initiate the 670G, you have to start initially on the 670 manual mode. You have to consider the manual mode at the beginning and at least 48 hours of insulin delivery on the manual mode before you can shift the patient to the auto mode. So every patient, regardless of previous experience, when the 670G is initiated, the patient has to be started on the manual mode. So now your patient is at minimum 48, actually even they recommend longer, the manual mode, and now it's time that you want to shift your patient to the smart guard auto mode. So it's basically regulated by an algorithm, and this algorithm is a response to the real-time data or the glucose values. The manual mode setting you will need to enter is basically the carb ratio. This is what you need to calculate, and the active insulin time. So these are the only two values that you need to enter in the pump. However, you should keep in mind that you have already entered all these values: the basal rate, the sensitivity, the target. Everything has been entered in the pump when you were on the manual mode. But now when you're shifting, all this will be left as backup. And what you need now is just basically the carb ratio and the active insulin, the duration of the active insulin. So the basal rate, the sensitivity factors, the glucose targets, you don't need to worry about. The pump will take care of this. And the goal of this is to keep the patient within this auto mode for at least 80% of the time in order to be able to achieve the time in range goals. If there is any issue, then the pump will push the patient out of this auto mode to the manual mode. If there were issues, for example, the patient was not calibrating, the blood sugar was persistently high, there are some sensor issues, etc. So the pump will automatically push the patient out from the Smart Guard auto mode to the manual mode. So the auto basal is the term that we use for the basal insulin when it is in auto mode, and this is adjusted every 5 minutes, and it's basically based on the current sensor glucose, and the values depend how much is pumped every 5 minutes, depends on how far and how long the sensor glucose has been away from the target, how rapidly it's changing, is it coming down quickly or slowly, and how much insulin, whether it's from a basal or a bolus, is available on board and the maximum delivery rate. So all of these are taken into consideration. So if you look at the two graphs here, the upper graph shows you a graph for a patient who's on the manual mode or the regular, for example, 640G or the other insulins that are not a closed loop. However, if we look at the lower graph, you can see the graph, how it's changing every 5 minutes depending on the sensor values. As I mentioned, that the glucose targets and the sensitivity factors are presets. The glucose targets actually are preset. So it is set at a level of 120. So the target is 120 milligram. It will start correcting when the blood glucose rises above 150 milligram. And as I mentioned, the autobasal every 5 minutes would adjust itself. And you may set a temporary target, a temporary that is higher than 120, for example, 150. That could be for 30 minutes up to 12 hours. And this basically depends on the amount of, for example, if the patient is planning to have any physical activities, etc. As I mentioned earlier, that the insulin sensitivity factor you don't need to worry about, and it will be calculated on its own by the pump. And as I mentioned earlier, if we go back to the previous photo, if you look here, you see it in blue, showing the sensor glucose and the blue smart guard shield. If we go to the next, you see now it's gray. The shield is gray, and you can see that there is an action that is requested by the patient to do. So you need to measure your blood glucose. So now the patient has been shifted from the auto mode to the manual mode because the patient failed to check the blood glucose. So sometimes things that could be very simple, for example, entering a blood glucose value is all what is needed so that the patient can go back to the auto mode. So as I mentioned before, that when you're using auto mode, you only need to calculate the insulin carb ratio and the active insulin time. The insulin carb ratio has a greater impact on the glycemia, not the active insulin time. It has really a minimum impact on the glycemia. So as I mentioned, that the targets, as I mentioned before, and what are the target blood glucose when the corrections will be initiated when the blood glucose is above 150. Something that we have to keep in mind that this is not an artificial pancreas. So the system is not yet fully automated. So it still needs frequent follow-up, especially in the beginning. The glucose values may not be perfect at the beginning. The patients that are used to tight glucose control will be very upset. They're not used to have those readings that are elevated. And the autobasal will adjust to better match the requirements, and this will happen by time. So what are the patient's responsibilities? The patient should be bolusing before eating. So as I mentioned, this is not yet a artificial pancreas. So still they need to do the counting for the carbs. And then they need to calibrate 3 to 4 times a day, especially before they go to bed. They need to respond to the alerts and prompts, for example, entering the blood glucose values, especially if they want to continue on the auto mode. What are the clinicians' responsibilities? They have to make sure that this is the most impact is the carb ratio. So they have to make sure that the carb ratio, the patient is doing what they're supposed to do, calculating the amount of carbs appropriately, and bolusing before the meal, 10 to 15 minutes before. The ratio, he needs to review it to make sure that the insulin to carb ratios are accurate. For the CareLink data and the CareLink upload, it's quite time consuming. However, they need to sit and look into it and discuss with the patient and explore. And we need to keep in mind that some situations, for example, if the patient is on steroids, the pump is not smart enough to detect that the patient is going to develop insulin resistance, for example, in the next few hours. Also, if the patient, for example, is going for surgery, etc. So still the pump is not yet at a stage where it can take care of these points. So what do we need to start the auto mode? So basically, we need the sensor. We need that the patient is at least on 8 units of insulin per day, not more than 250 units per day, that the patient is, the blood glucose is currently entered, and that we have already programmed the carb ratio and the active insulin time, and at least 48 hours on manual mode. And as I mentioned, that a week is even better. So for the best practices, we should set some guidelines, collect at least 6 days of manual mode before shifting to auto mode, look into the care link, discuss it with your patient, assess the time in range, assess the glycemia, and discuss with the patient what are the reasons that he or she are exiting from auto mode. Make settings adjustments and schedule a follow-up with the patient. So here are some of the reports. I will not go into it in detail. So this is the CareLink adherence report, which tells us how much the patient is checking the blood sugars, how many times they're changing the infusion set. This is the CareLink weekly review report in details, and it shows you the time where there is the patient is shifted from auto mode to manual mode, etc. The meals, the boluses, the carb ratio, the counting, etc. All the details, pre and post meal blood glucose in the bolus wizard, the logbook report, and more we can see in this pump, similar to for example, the output from the Freestyle Libre, etc. So where we have, it shows us the time in range, the percent, how much of the time the patient is well controlled, how many times, or the percent of hypoglycemia, etc. So because of the sake of the time, I'm not going to go into the details. However, just to mention the pivotal trial for the Minimed that was conducted on children, 105 child, and adolescents and adults. And it was 3 months of unsupervised at-home use of the Minimed 670 system that was shown that it was safe in children and adolescents and adults with type 1. And the CGM component was accurate. And the auto mode control was associated with reduced glycemia, glycemic variability, greater time in range target glucose, less exposure to lows and highs, and lowered A1C. So very important, we have to know what are the limitations of this pump. The preset blood glucose target of 120 is considered high for a quite good number of patients, particularly, for example, pregnant women or women planning pregnancy. So 120 is quite high for a pregnant woman or one who's planning pregnancies. Also, patients on high-dose steroids, and if they're actually on tapering dose, again, the pump cannot predict insulin resistance, etc. And patients who are very ill or are unstable or having some hemodynamic instability. And of course, patients that are not controlled or have major depression disorders, psychiatric disease, or are not adherent to their therapy or visits. The need to check blood sugar 4 times a day is still a problem, and they have to understand this. And many patients, particularly in some of the centers, have noticed that they're really frustrated because of the amount of work they have to do when using this pump. So only recently, just this year, was the Minimed 780G, the advanced hybrid closed loop insulin pump. It is an automatic basal insulin delivery again, and it can suspend before low, similar to the Minimed 670, with some modifications that may mean a lot for our diabetic patients. So it is automated. It helps the patient to reach the glycemic target, time in range above 70%, and an A1C below 7%. It autocorrects highs early before they occur. And you can actually personalize the goal for this patient. So in comparison to the 760, where we mentioned, sorry, the 670, when we mentioned that the preset target is 120, here you can personalize. So it could be 100, 110, or 120. So this really means a lot for the patients that were unable to utilize the 670 unless they were actually on auto mode. However, unless they were on manual mode. However, they were unable to utilize it if on auto mode. In addition, that it autocorrects if the blood glucose is at 120. So in comparison to the 670, where it would correct at 150, here it will not allow the glucose to go above 120. So it autocorrects every 5 minutes. And the good thing that it has fewer auto mode exits. So in comparison to that pump where they would have frequent exits, here there are less exits. So it actually is more flexible. It gives the patient more time to relax. The goals are personalized. And what is interesting, that perhaps carbs like small meals, like for example snacks, you may not need to worry about it. So this is something that they're still looking into, that perhaps patients, when they eat small portions like snacks, for example, they need not to worry about bolus in comparison to the 670, where they would need to bolus whether it's a snack or whether it's a major meal. In the ADA meeting 2020, the virtual meeting that was conducted this year, there were actually a handful of presentations about this pump in particular. I just picked a few of them. The time? Okay, just 2 minutes, okay? So this safety study for the pivotal trial, where they included 39 adolescents and 118 adults, they found that when using this pump, that's the mean glucose was 140, the time in range 78%, the time below range was 2.6%. So it was safe, and it significantly improved the A1C and the sensor glucose. And this is just a study to show the quality of life. So in comparison, they compared this pump to the 640G, which is the suspend before low. So the result was that it showed that the advanced hybrid closed loop, which is the 780, compared to the 640 mode, has the potential to increase satisfaction and also improve the quality of sleep in adolescents and adults with type 1 diabetes. So this is my last slide, and I would just want to say that, inshallah, there is hope at the end of the tunnel. Yes, we're taking slow steps, but alhamdulillah, we're persistent. We're continuing to excel, and hopefully, inshallah, we will reach at the point where we would be able to have an artificial pancreas. Thank you very much for your attention.
Thank you, Dr. Hawazin, for this and excellent presentations. Now I will introduce, this is really my pleasure to introduce Dr. Naweed Zaman. Dr. Naweed Zaman, he's having American Board of Internal Medicine and Endocrinology, and he's Assistant Professor of Internal Medicine and Consultant Endocrinologist, Department. Okay. الصوت ايوه ماجد الصوت واضح ولا لا؟ Okay. Again, just I'm introducing Dr. Naweed Zaman. He's American Board of Internal Medicine and Endocrinology, and he's Assistant Professor of Internal Medicine and the Consultant Endocrinologist in the Department of Internal Medicine, College of Medicine, Teba University, as well in Medina Diabetes Center and Medina Medical Centers. To continue with the talk of Dr. Hawazin, Dr. Naweed Zaman, he will talk about advanced diabetes management by targeting time and range. دكتور نويد تفضل.
السلام عليكم ورحمة الله وبركاته. You can see my slides. My voice is clear. Okay. Shukran, Dr. Iman. Thank you for the organizing and the scientific committee for the invitation. It is a great and excellent experience to present among those pioneers in during those tough conditions. My talk today will be about particularly advancing diabetes management in time and targeting time and range. These are my slide of disclosures. We have three CGMs available right now in Saudi Arabia, and I'm not in my talk promoting for any of those CGMs. I'm just going to detail the time and range part of the AGP and how we can use that to help with our patients. So in the next 20 to 30 minutes, inshallah, we'll be talking about the CGM metrics, the time and range, what's the relation with the HbA1c, if there are any data to validate this important measure as an outcome measure for diabetes outcome trials, and of course, briefly on the consensus recommendation and how can we help our patients to achieve the recommended time and range. And I'll end up my presentation, inshallah, with one or two case scenarios if the time allows about the time and range. So why do we need CGMs? Because as we are all aware that HbA1c is basically is giving us an average, and it does not tell us anything about the excursions or the glucose variability. And the self-monitoring blood glucose, it provides only information at one point of time. It's limited by the frequency of testing, as we're aware that our patients, and most of our patients, have difficulty to test frequently. So we have some limitations. Although the HbA1c is an excellent biomarker, has been used for the last 3 decades, and it is a marker that has been used exceptionally in all of the diabetes outcome trials. And we'll see if the time range can relate to that during our presentation. So we need to go beyond A1C, and that is what was the aim of most of the expert groups who actually came up with the guide and the consensus statement, because the A1C is not one size that fits all. And as I explained earlier, the severity of the excursions cannot be explained by the A1C. So for example, if you look at 3 patients with an HbA1c of 7%, you can see that the patient on the left side has blood sugar in range up to 18%, and the one that's in the middle is up to 63%, and one's on the right side is up to 100%. So 3 patients with similar A1c and have different glycemic profiles. I usually tell that to my patient. You know, if the patient is driving car on the highway and they have been stopped by the police, they've been pulled on the side, and they say, you know, because they stopped because they were driving over limit, and the driver replies, say, but my average speed was good. This is not acceptable. So the average is not acceptable because the patient still has the highs and lows to deal with throughout the day. So again, as I explained earlier, the self-monitoring blood glucose tells us only does not tell us the full picture. So the CGM basically tell us the full story. It is like a movie. It gives us an insight about the trends in between the blood glucose test. It's not only to looking into the numbers. It's the whole movie that we have to comment on. So what are those metrics? A group of the experts who are interested in diabetes technology came up back in 2017, and they discussed the most important metrics that can be used in different available CGM systems. And they came up with those standardized metrics. And out of those 10 standardized metrics, as I can see, it's about the time and range and time above range, time below range. So they agreed that, you know, that any to comment on the data of the CGM has to be worn at least 14 days. It has to be active for at least 70% of the time. And they also comment on looking into the mean glucose, or the glucose, also the glucose management indicator. It's also important to comment on the glycemic variability, and the rest of the data is basically looking into the ranges. As you can see in this slide, in the green one, the time and range that is the target of our lecture. And the time and range can be achieved by decreasing the amount of the percentage of the time the patient spent in time above range, which you can see in yellow, or time below range. So what's the definition of time and range? The time and range is amount of time the glucose levels fall within a target range that's usually expressed in percentage and CGM readings. And target range of 70 to 180 milligram per deciliter is set up for most of our patients with type 1 and type 2 diabetes. A more tighter range of 63 to 140, as we can see in the consensus statement, is set up for patients during the pregnancy. And then those targets has to be expressed in the form of percentage, as we're going to see later on. What's above range and what's below range? So above range is usually is divided into two levels. The level, if it's level 1, if it's from 180 to 181 to 250. Level 2 is if it's more than 250. And again, it goes the same for the time below range. Yes. All right, so sorry for the interruption. So time above range usually is divided into two levels. Level 1, if the readings are between the 180 to 250, that's captured by the CGM. And reading level 2, if the readings are above 250. Again, the time below range is defined if the readings are below 70. So if they are below 60, they are ranging between 54 to 69, so that's level 1 time below range. And if they are below 54, so that's level 2, more dangerous time below range. All right, so is there a relationship between the time in range and the hemoglobin A1C? Actually, analysis were conducted using 4 randomized controlled trials by Dr. Roy Beck back in 2019 that involved around تقريبا 550 adults with type 1. And they came into agreement that if the time range around 70%, between 70 to 180, that's equal or is basically coming to the A1C of 7%. So, and they came up with this along with the other studies done by Dr. Vigresky, that if there is a time range of 70%, so that's almost equal to 6.7% of A1C, and every 10% increase in the time range, basically that is being related to the A1C is a 0.8% decrease in HbA1c. So what we are expecting that every 5% increase in the time and range is associated with a clinically significant benefit, hopefully over long term with our patients. It's an exceptional marker. It's a very important marker, but is there an evidence? Can we use this? Has it been used by experts in long-term diabetes complication trials. So it's a time to connect the dots. We don't have, of course, so far any randomized controlled trials correlating this time range with the microvascular or macrovascular outcome in type 1 or type 2 diabetes. But we have those two landmark studies, which are one of the best available evidence I can come across for my talk by Roy Beck and Dr. Liu. And we'll see if there are any relation for patients staying in a good percentage in time and range versus developing any complications. So the first study was basically analyzing the DCCT trial, as most of you are aware of this trial. And basically in the DCCT trial, what happened is around 1,400 patients. They were asked to do around 7-point glucose profile. And they were asked to do that actually quarterly, so every 3 months for 6 years. I actually did the math, and I found that at the end of the study, they actually had about 250,000 of blood glucose readings. And as you are aware that those patients in DCCT were divided into the intensive group and more relaxed group of diabetes management. And approximately there was around 77% of the data available, and they did this math calculation and they computed the time range of 70 to 180 each quarter by calculating the percentage, and also they checked the mean glucose percentage that's reaching more than 180 or more than 250. And what they came across is that they found that in those quarters, those patients who had the lowest, in the lowest time and range quartile, they had the highest percentage of retinopathy. And the same goes along also the highest percentage of microalbumin or development of microalbuminuria. So those who had the lowest time and range in their study, of course, that was a retrospective analysis of the data, only that's available on 1 day quarterly, but still, based on those data, they found that those patients who had the lowest time range, they had the highest rate of developing the retinopathy as well as microalbuminuria. At those days, of course, there was no, it was not commonly used, the insulin pump, and the CGM were not available. So the best time range they were achieving in the intensive group treatment was around 41%. And what they can found is that they're doing some calculation, a 10% drop in the time range increased the risk of retinopathy by 64% and microalbuminuria by 40%. Of course, before I go further, one of the setbacks of this study, theoretical concern, that the participants were doing the 7-time measurement, and it's possible on the days when the measurement was asked them to be done, the participants were more diligent with their diabetes management. But this is one of the largest number of data we have available. Let's see about type 2 diabetes if we have anything more recent. So this study was done by Liu et al. And they actually had a good number of patients who were admitted to the hospital, around 3,000 plus patients. And they investigated if there is an association between the time and range that was assessed by wearing a CGM. That was a CGM that's applied for 3 days. And development of different grades of diabetic retinopathy. Of course, the CGM generated a record of 288 measurements per day. And what they found, if you can see on the left side, that's the mild non-proliferative diabetic retinopathy, and the right side, that's the vision-threatened diabetic retinopathy. And you can see a nice decrease in the bars. So that the darkest bar you can see in each category is the time range that's more than 86%. And the lightest bar that's on the left side, you can see in each category, that's when the time range was less than 51%. So when the time range reaches a higher percentage, you can see there is a decrease in the prevalence of diabetic retinopathy at all stages, either mild or moderate, or even the vision-threatened diabetic retinopathy. trying to find if there is any relation between time and range as well as the macrovascular complication. I came across this study, which was published a couple months ago, and they tried to investigate if there was an association between the time range obtained from the CGM or the and the carotid intermediate thickness. As you might be aware, that the carotid intermediate thickness is a surrogate marker for cardiovascular disease, and data were collected by 2,000 plus patients. And before going to time and range, what they found, those who had a higher A1C, which we are all agree upon, they had a higher prevalence of carotid intermediate thickness, which translates into a higher risk of the cardiovascular disease. But they also found that those who had a less percentage or less in time remaining into time and range, so less than 40%, they actually also had a higher prevalence to develop the carotid intermediate thickness. This is the best available evidence I can come across in terms of the macrovascular complications. Now I will go through the consensus recommendations on time and range that was published last year in ATTD 2019 meeting, and they came across those metrics I showed earlier. And basically, they came up with the standardized AGP report, which actually shows the time range in the shape of bars, very colorful, that's easy to read, easy to understand, either by the healthcare professional and by the patients. And the same page, if you're using different companies have different form of displaying this report. But for example, for the flash CGM, you can see the actually the AGP on the same page, and also some of the daily data on the same page. On the left side, you can see they actually have placed the targets, so you don't forget, if you're kind of forgetting the targets of your patients, you can see those. So what they suggested is basically, that most of our type 1 or type 2 diabetic patients, they should have a time range between 70 to 180, and the percentage of that should be more than 70%. And this applies to most of our type 1 and type 2 diabetic patients. And it's not only achieving time and range. To achieve that, you have to decrease the amount they are staying in time above range, as you can see in the yellow and in the yellow bar, in the dark yellow bar above, that they are recommending that they have to remain less than 25% into level 1 time above range, and less than 5% level 2 time above range. In terms of the time below range, they're recommending that the patients should remain less than 4% in the level 1 and less than 1% in the level 2, which I defined earlier. And that goes for most of our type 1 diabetic patients. It's easy to remember, 70%, boom. What about those patients who are elderly, who are at risk of hypoglycemia? They actually, as we do actually with our A1C goals, they actually decreased and relaxed the percentage a little bit. And they said, of course, the overall hypoglycemia should be less than 1%, either level 1 or 2. The percentage of time they should remain for the in the time range should be around 50% or more, and they can go up to hyperglycemia either both levels less than 50%. And you can see that 70% as also applies for the pregnancy in type 1 or pregnancy in type 2. Actually, in type 2 or gestational, they did not come up with the exact percentage because they were having difficulty to find an evidence to that. But in type 1, they said, and those patients has to be in the timer and the target more than 70%. But note the difference. The target here is not between 70 to 180. It's about 63 to 140 milligram, as you're all aware. Increasing the glucose fluctuations and hyperglycemia will increase the risk of complications that can come up with the pregnancy. So in general, I want you to remember the 70% readings has to be between 70 to 180. And if they are pregnant, then it has to be between 63 to 140, more than 70%. And always to achieve that 70% target, you have to focus also on decreasing the amount of time the patient is spending in time above or below range. One of the things I just want to add here is that when the patient comes into the clinic, and I'm sure that most of you are finding difficulty to have this percentage achievable in the first, second, or even the third visit, is recommended that they, that by the consensus that in between the clinic visit, the aim is to improve the time and range by 5%. And that is equal to around 15 minutes per day. So we are not jumping from 40 to 70 in 2 weeks. We are aiming to improve it slowly because the improving time and range needs behavioral changes, and that takes a long time to do. And that's again the same thing, but it's in the same report. You can see on the left side, they actually placed it, and you can see the normal values on your patient's report, so in case if you forget them. And how to achieve that recommended time and range is basically to achieve that recommended time and range, you really need to work hard toward reviewing the whole AGP report, because time range, above range, below range, that's like 5 out of 10 metrics, and you have to achieve the best available target in those in those ranges. And to do that, you have to review the report very closely. So first thing you should do is to check if the patients have enough data. Second thing is, as you are taking history from the patients, like make sure that you know when the patient exercises, what kind of food they're eating, what kind of medical issues they have, do they feel or they have episodes of hypo and hyperglycemia, just a regular history. And it's always a good idea to involve the patients, and because the AGP reports, the beauty of AGP reports is visual, so you can always involve the patients and ask them what do they see, and if they see anything that's very achievable, they can change in their behavior, and that will help you to with the shared decision making. And that will give the patient also a sense of control, and provides a personalized medicine. So it's AGP, it's a great tool for most of the visual learners, and I believe most of our type 1 diabetic patients they will definitely help you, inshallah, if you share the report with them. To always start by looking into the patterns of the low glucose, because the low glucose, the hypoglycemia, leads to fear and anxiety, a lot of complications which are acute. So always start to see if their patients having hypos, and check if the hypos are fasting or postprandial, or if they're postprandial, how many hours after meal, if they're happening on the same day, every day, and so on. And then you can go and look at the pattern of the high glucose, and check also the variability, and see if the patients have like discrete and very abnormal behaviors different times of the day, which will lead to a high glucose variability. Keep the previous AGP report in your records, or you can actually see them online if you don't want to print them, and reinforce a positive experience every time you see the patient, to make sure that they listen to you and come back the next clinic visit with a new behavior. And that will lead to assured decision making, set goals, empowering the patients, and that will help you to achieve the time and range, inshallah, over the course of the treatment. As we are all aware, diabetes is a very complicated, and data should not be viewed and ask the patient to achieve the goals within 1 or 2 visits. And always ask the patient and write it in your notes to do something, and come back and see if that has affected. Since we have the technology, it will be very easy to use that in our clinic. I think I have 5 minutes, so I'm just going to go quickly through 2 of the case scenarios. The first one is Miss A. She's a 36-year-old housewife. She's a known case of type 1, and she takes her medications regularly. She weighs around 70 kilograms. She's on Lantus 30 units, Lispro 8-12 units. She's carb counting. Her carb ratio is 10. Her ISF is 65. That's how she's correcting. Her target range is between 70 to 130. Her HbA1c was 7%, and she came to my clinic and she wanted to fast safely, and that was before Ramadan. And as you can see here, just by looking at the AGP from her flash glucose monitor report, that she's been having a lot of hypos throughout the day. And although her the median is not bad. It's actually within range, but she's still having a lot of hypers and hypos, and you can see that she is at a very likelihood to develop hypoglycemia throughout the day. It's not like at one particular time, and she wants to fast. So what I did with interpretation when she came to my clinic, I made sure that she has 14 days of data. I showed her the lows so she understand, because she always want her A1C to be around 6%. She's okay being low, but I showed her how dangerous that can be. And then I showed her the highs that's going post meals and high glycemic variability. And of course, those are the things that I commented on. If she has nocturnal hypoglycemia or preprandial hypoglycemia or postprandial hypoglycemia, and the same goes for the hyper. And try to make sure that always start with hypos and see if that corrects your issue. If not, then they can go to the hyper. So what I did, just based on this report and reviewing her AGP, that I reduced her basal insulin she was taking. I reinforced the carb counting with the clinical dietitian, and she was not really using the correction doses correctly. So I asked her to do that, and she came back a month later with a better looking curve, and a time range reaching up to 86% and MDI without a pump. But you still can see that she still has a lows up to 6% level 1 and 2, but that is still much better than what we used to have before. Last case is Mr. A, and the reason I placed him in Mr. M, I'm sorry, the reason I placed this guy in my talk, because I just want to show you, this is a 55-year-old, I think 56-year-old type 1 diabetic, and he's been following with me virtually. I haven't really met him yet. And I know all his data through virtual clinic. And he's, mashallah, tabarakallah, he's very active. He walks daily, he counts carb. He's been diabetic for 30 plus years. And this was his, basically the CGM data back in Ramadan. And you can see that, his time range is like 89%. This is much better. And this is actually more than what's recommended according to his age and his condition. And his lows are still, 6%. You can do better a little bit, but he wants to be in tight target. He's like scanning more than 12, 14 times a day, and he's watching his carbs. But the reason I'm showing you this, because if you see this in Ramadan, this guy was eating much less carbs. And basically, when he was eating less carbs, his hypos were lower. And that has changed after Ramadan. His target time and range decreased from 89% to 85%, and his hypos increased because he's back to eating more carbs after Ramadan. And this is kind of like showing to the patient that, all right, change in your diet can lead to change in the percentage of time and range, and that will lead to development of complications in long term. But overall, this guy is an excellent, and I hope that most of my patients can be like him. So what's needed from us, what's needed from educators is we need to review the guidelines, and we need to manage according to the available resources in our facility. We need to educate our educators, the nurses, the dietitians to deal with such technology. We should have dedicated clinic for technology. We should not be seeing type 1 diabetic patients who are on technology with regular type 2 or other type 1 patients, because those patients take longer time, and this is not acceptable to see them with other patients. So we should have a dedicated, as much as possible, dedicated clinic space, computer, and staff. We should download and teach the patient and encourage them how to download the data, and always review the data with them and give them clear instructions, and bring them back in a couple of weeks to see if your instructions has actually worked. So take-home message: SMBG and HbA1c does not distinguish patients with glycemic variability and with glycemic excursion. I mean, as a component of diabetes self-management, daily use of CGM now is recommended by the ADA 2020, because that helps to obtain an immediate feedback on current glucose level, and that will lead to change in behavior. This information will help our patients to, because they will give them informed therapy decisions regarding their mealtime and correction, as well as on the effect of exercise on their body. So time and range is a very useful tool to evaluate in glycemic control. In clinical practice, it should be used as a powerful educational outcome. And that should complement, it's not a replacement, it should complement an HbA1c, as I believe so far, for a wide range of people with diabetes. And time and range target values should be considered as an integral component of CGM data analysis for day-to-day treatment decisions. And thank you very much.
Thank you, Dr. Naweed, really for this excellent presentations. Now we'll go to the questions. I have 2 questions for Dr. Hawazin. Okay. I have 2 questions for Dr. Hawazin. Okay. طيب. I have one question for you. That's from your experience, how much accurate can time and range with a precise reading for glucose profile?
So accuracy of time and range versus the glucose. If I believe the question is like the time and range correlating it with the average or the HbA1c.
Actually, he said his questions reading for glucose profiles. Maybe I guess that's how accurate that we use the time and range.
So here's the thing, the problem in one of the major problems I think is as a healthcare professionals, also for the patients and educators, that they depend on the CGM data as they're using the numbers, and they're using them as they are using the SMBG. Which is wrong. You have to use the data that's coming out of the CGM overall. You have 10 metrics to look at, and if you use them all of them together, then you are doing very well in correlating with an average and HbA1c.
Okay. So go back to Dr. Hawazin. Dr. Hawazin, you have one question. It's a long one. From which age can we start the pump, and what A1C reading that is needed in children? And is there any reported hypoglycemia attacks? And does it require highly educated parents?
Okay, I would answer this question partly. And I would, first of all, I'm not a pediatrician. I'm a adult endocrinologist. However, for pediatrics, Medtronic approved the use of insulin pump for children that are above 7 years. So anybody who is above 7 years of age and fulfills the criteria for to be on an insulin pump, then they could have the pump. For the patients that I treat in particular are adolescents, so patients that are 14 years of age and above. And for that, we set criteria. And the most important criteria is the willingness of the patient. Is the patient interested? Because insulin pump is not something that people would think it's autonomous and it would function on its own. As I mentioned in the presentation, that it requires a lot of input from the patient. So the patient should be able to do self-monitoring and calibration a minimum of 3 to 4 times a day. So again, it's not like less finger pricks. It's not less work to do. Yes, it's less of injections. However, the idea is not if they think that it's less of finger pricks, etc. It's not the case. They have to do the self-monitoring, as I mentioned. They have to learn how to do the carb counting. They have to be able to calculate the carbs, and they have to know simple technology. And it's not so difficult if most of the children or adolescents or even adults are into smartphones. So if they know how to use a smartphone, then they would be able to use a pump. So it is not difficult. It does not really require a high level of education. What it really requires is patients that are highly committed, I would say, willing to do all the instructions and are keen on follow-up and keen on contact, whether with the physician, with the educator, dietitian, the company representative, or even the helpline. So these are the criteria that we set. for patients. Of course, patients that were on MDI and their blood glucose was well controlled and they would like to be on the pump for quality of life, yes, sure, we may consider such patients. Are there any parts of the question I did not answer, Dr. Ayman?
I think you answered. The second questions, they ask you that, can you tell us about the commercial name and the contact to have this new pump and the cost?
Okay. The pump, if you're talking about the 670, the 670 will be available soon in Saudi Arabia, inshallah. If you're talking about the 780, the last one I presented, then that will be released perhaps late this year. I'm not sure it will be available in Saudi Arabia until next year, release by the end of this year in, for example, Europe, etc. How much does it cost? I don't know the price of the new. I know that the ones that we use, the 670, which is the suspend before low pump, which is quite good. It's a sensor augmented pump, and it has the feature of suspending the release of insulin before the low, and that is about 35,000 in that range. And the pumps that we use and are approved is the Medtronic company. I know there are other companies, however, we're used to, or this is the pumps that we're using in the National Guard.
Okay, thank you, Dr. Nawi. There is questions for you. That's you have come about the study, the outcome, pregnancy outcome, and time and range.
There is a study, based on that, I think it was, I'm not recalling it right now. There is one that's done by the Libri company, but with a better time range and outcome, yes, there is. It was recently published, yeah.
Okay. So you recommended that to use that during pregnancy?
Of course, yeah. I recommend to use it for all our patients, yes, either pregnant or not.
Okay. Majid, you have any more questions? That's the question I have it till now. Okay. طيب, at the end, really, I'm thanking Dr. Hawazin and Dr. Nouid for this really excellent presentations and response to the questions. Thank you.
Thank you. Thank you, Doctor.
Thank you. Thank you for this opportunity.